Hello everyone, today we will be discussing the topic of drugs affecting the respiratory system. Beta-2 receptor agonist, also known as B2RA bronchodilator agents, are widely used for patients of all ages to treat reversible bronchoconstriction caused by asthma, reactive airway disease, also known as RAD, or COPD. A variety of beta-agonist bronchodilators are available, and the medications come in multiple forms and delivery systems. Albuterol, with the brand names being ProAir, Ventolin, and Proventil, is the most commonly prescribed drug in this class. Other sympathomimetic bronchodilator medications used in primary care are the short-acting B2RAs. Metaproterenol, with the brand name being Alupent, terbutaline, with the brand names being Brethine and Breathair, Perbuterol, with the brand name being Maxair, and Levalbuterol, with the brand name being Zopanex. The long-acting B2RAs include arformoterol, with the brand name being Brovana, formoterol, with the brand name being Foradil, and salmeterol, with the brand name being Ceravent. Ultra-long-acting B2RAs include indicaterol, with the brand name being Arcapta neohaler, olodaterol, with the brand name being Straverti Respimat, and Volanterol. Albuterol is a selective beta-2 agonist with some minor beta-1 activity. Levalbuterol is similar to albuterol, where the S isomer from racemic albuterol is removed, leaving the R isomer, which has fewer adverse effects. Salmeterol, formoterol, and arformoterol are long-acting inhaled bronchodilators with a half-life of 10 to 12 hours. Salmeterol is more selective for beta-2 receptors than albuterol and has minor beta-1 activity. Sympathomimetic bronchodilators have relatively few contraindications to their use. Cardiac arrhythmia is associated with tachycardia or heart block caused by digitalis intoxication, angina, narrow-angle glaucoma, organic brain damage, epinephrine only, and shock during general anesthesia with halogenated agents are all contraindications to beta-2 agonist. For patients with diabetes mellitus, there is a potential drug-induced hyperglycemia that may result in loss of diabetic control when using any of the beta-2 agonists, and their insulin dosage may need to be increased. In December 2008, a follow-up FDA advisory was issued stating that the risk of salmeterol, with the brand name being Ceravent, and formoterol, with the brand name being Foradil, outweighed the benefits and that they should not be used singly in asthma for all ages. Terbutaline pregnancy Category B. Others Category C. Children. Albuterol safe for children of all ages. Salmeterol should not be used in children younger than age 4 years and never singly. Adverse reactions to the beta-agonist bronchodilators are usually transient, and discontinuing the medication is not generally necessary. However, a temporary reduction in the dose may alleviate some of the side effects. Slowly increase the dose after the reaction to the optimal dosing has subsided. Tachycardia and palpitations are reported in 14% of patients who use these sympathomimetic bronchodilators. The beta-agonist bronchodilators exhibit some central nervous system excitation effects with tremors, dizziness, shakiness, nervousness, and restlessness reported in some patients. Headaches may occur with bronchodilator use in 2% to 28% of patients. Salmeterol and other LABAs have a documented increased risk of exacerbation of severe asthma symptoms if the patient is deteriorating. To avoid this risk, none of the LABAs should be started in patients with acutely deteriorating asthma and are best used in combination with an inhaled steroid. Because of the cardiovascular effects of the bronchodilators, careful monitoring for drug interactions is necessary. If any of the beta agonists are prescribed with digitalis glycosides, caution and careful monitoring of the patient's electrocardiogram is necessary because there is an increased risk of cardiac arrhythmia. Beta agonists used with beta adrenergic blocking agents, including ophthalmic preparations, may result in mutual inhibition of therapeutic effects. Tricyclic antidepressants and monoamine oxidase inhibitors, also known as MAOIs, used with albuterol, metoprolol, or terbutaline may potentiate the effects of the bronchodilator on the vascular system. Clinical use: bronchospasm. The bronchodilators are used primarily in the treatment of bronchospasm associated with asthma, bronchitis, acute or chronic, and COPD. The dose of albuterol metered dose inhaler, also known as MDI, in children older than age 4 years and adults is 2 puffs every 4 to 6 hours. The dose of albuterol, with the brand names being Ventolin and Proventil, delivered via nebulizer for children older than age 12 years and adults is 2.5 milligrams or 0.5 milliliters in 2 milliliters normal saline. Levalbuterol, with the brand name being Xopenex HFA, which stands for hydrofluoroalkane, inhaler, is an FDA approved for use in adults and children age 4 and older, with a dose of 1 to 2 puffs repeated every 4 to 6 hours for wheezing appropriate for all patients. Salmeterol, with the brand name being Ceravent Discus, is a long-acting bronchodilator available in powder for oral inhalation, packaged in a specially designed plastic delivery device that delivers 50 microgram per inhalation. The dose for children aged 4 and older and adults to control asthma and prevent bronchospasm is 1 actuation/puff twice a day. Salmeterol is not to be used for short-term bronchospasm relief. Exercise-induced bronchospasm, also known as EIB. The dose of albuterol MID to prevent EIB is 2 puffs 15 minutes before exercise, which should prevent EIB for 2 to 3 hours. The dose of salmeterol is 2 puffs 30 to 60 minutes before exercise. Salmeterol should prevent EIB for 10 to 12 hours. Leukotriene modifiers taken daily may decrease EIB symptoms in 50% of patients, but patient will still need to use albuterol before exercise. Beta agonist, rational drug selection. The expert panel 3 says any short-acting beta agonist can be used in adults. Patient age. The only short-acting bronchodilators that can be prescribed for children younger than age 4 are albuterol and metoprolol. Levalbuterol is labeled for use in children older than age 4, and the expert panel 3 guidelines indicate that it should not be used in children younger than age 4. Albuterol is by far the most frequently used medication in clinical practice. It is readily available and is safe to use even in infants. Cost. Of the short-acting bronchodilators, albuterol is the least expensive, especially if a generic formula is prescribed. The administration of bronchodilators via MDI can be difficult for most adults and all children. Learning to coordinate the release of the medication from the inhaler with a deep breath is difficult. Use verbal instructions as well as actual demonstration with a placebo inhaler to reinforce the written instructions. These instructions and demonstrations should be repeated at follow-up visits. To use an inhaler properly, the patient should first exhale and then tilt the head slightly back and place the inhaler mouthpiece either about 2 inches from the open mouth or between the open lips. While inhaling, the patient should press down on the canister, breathe in slowly and deeply, and hold his or her breath for 10 seconds. Count to 10, or as long as comfortable. If 2 puffs are prescribed, then the patient should wait at least 1 full minute between inhalations. Hello everyone. Today we will be continuing the topic of drugs affecting the respiratory system. Theophylline and caffeine have an effect on most of the major body systems. They are powerful central nervous system stimulants, often causing insomnia and excitability. Although both drugs have cardiovascular effects, theophylline has a greater effect on the cardiovascular system. Theophylline directly stimulates the myocardium and increases myocardial contractility and heart rate. By relaxing vascular smooth muscle, theophylline dilates the coronary, pulmonary, and systemic blood vessels. Both theophylline and caffeine increase gastric acid secretion and may produce nausea and vomiting, although this reaction is probably due to central nervous system effects. Both methylxanthine stimulates skeletal muscle, causing tremors. Theophylline acts directly on the renal tubules to cause increased sodium and chloride excretion. By increasing renal blood flow from increased heart rate and the glomerular filtration rate, theophylline and caffeine also cause diuresis. Often these effects occur when theophylline is within the therapeutic range. Theophylline. Pharmacokinetics. Absorbed rapidly and completely from gastrointestinal tract. Distributed widely. Volume of distribution altered in premature neonates, older patients, cirrhosis, pregnant women in their 3rd trimester, and critically ill patients, probably because of altered protein binding. Metabolized extensively in liver via cytochrome P450 into caffeine. Disease states and cytochrome inducers can influence metabolism of theophylline. Eliminated renally. Precautions and contraindications. Monitor patients with hypertension, ischemic heart disease, coronary insufficiency, congestive heart failure, or a history of stroke and cardiac arrhythmias. Monitor for theophylline toxicity. Prolonged clearance and half-life in neonates and older adults. Pregnancy category C. Excessive doses may lead to toxicity. Incidence of toxicity increases when serum theophylline levels are above 20 micrograms per milliliter. Toxicity is found if serum theophylline levels reach 25 microgram per milliliter in 75% of patients. Adverse drug reactions are uncommon with serum theophylline levels below 20 microgram per milliliter, although some patients may show toxic effects between 15 and 20 micrograms per milliliter, especially during initiation of therapy. The central nervous system adverse effects that may be seen include irritability, restlessness, seizures, and insomnia. Gastroesophageal reflux may occur. Possible cardiovascular adverse effects include palpitations, tachycardia, hypotension, and life-threatening arrhythmias. Other adverse effects include rash, diuresis, and tachypnea. At serum theophylline levels above 20 microgram per milliliter, patients may experience nausea, vomiting, diarrhea, headache, insomnia, and irritability. At levels above 30 microgram per milliliter, the patients may have hyperglycemia, hypotension, cardiac arrhythmias, tachycardia, seizures, brain damage, and death. Adverse drug reactions for caffeine includes the following: cardiac arrhythmias, tachycardia, insomnia, agitation, irritability, headache, nausea and vomiting, and gastric irritation. Food and drug interactions. Many medications act to either increase or decrease theophylline clearance because of metabolism via cytochrome P450 isoenzyme, cytochrome P1A2, cytochrome P2E1, and cytochrome P3A3/4 substrate. Of significance is smoking tobacco, which increases theophylline clearance. The sedative effects of benzodiazepines may be antagonized by theophylline. Concurrent use of theophylline with beta-2 agonist bronchodilators may result in additive toxicity. Lithium levels may be reduced by theophylline. Theophylline elimination may be influenced by the patient's diet. A low carbohydrate, high protein diet increases the elimination or shortens the half-life of theophylline. A high carbohydrate, low protein diet decreases the elimination or lengthens the half-life of theophylline. A diet that contains a lot of charcoal broiled foods accelerates the hepatic metabolism of theophylline because of the high polycyclic hydrocarbon content. Caffeine is metabolized via the cytochrome P450 isoenzyme, cytochrome P1A2, cytochrome P2E1, and cytochrome P3A3/4 substrate. Therefore, other drugs metabolized by these isoenzymes will possibly interact. Cimetidine, ketoconazole, fluconazole, mexiletine, and phenylpropanolamine may impair caffeine metabolism, leading to increased serum levels. Caffeine elimination may be increased by co-administration of phenobarbital and phenytoin. Theophylline is not recommended for first-line therapy in COPD. The dose of theophylline for asthma and COPD varies with the patient's weight and serum theophylline levels. The adult patient older than age 16 years is started on a dose of 6 milligrams per kilogram per 24 hours or 400 milligrams per 24 hours, whichever is less, divided at 6 to 8 hour intervals. The maximum dose for patients aged 12 to 16 years is 13 milligrams per kilograms per day and 10 milligrams per kilograms per day in healthy adolescents older than age 16 and adults. Children age 5 years or older, 16 milligrams per kilograms per day, maximum 400 milligrams per day. 1 to 9 years, maximum dose 24 milligrams per kilograms per day. 9 to 12 years, maximum dose 20 milligrams per kilograms per day. 12 to 16 years, maximum dose 18 milligrams per kilograms per day. Apnea of prematurity. A loading dose of caffeine citrate 10 to 20 milligrams per kilogram is given in the treatment of apnea of prematurity, with a maintenance dose of 5 milligram per kilogram per day, which can be increased to 10 milligram per kilogram per day for persistent apnea. The American Academy of Pediatrics Committee on Fetus and Newborn no longer recommends theophylline for apnea of prematurity. Rational drug selection. Because theophylline is the only xanthine derivative commonly used in asthma and COPD, the selection process basically involves choosing between the different forms of theophylline that are available on the basis of their cost and convenience. There are immediate release, time release, and liquid formulas. Capsules that can be opened and sprinkled on soft foods are convenient for some patients. Immediate release. Children younger than age 12 usually require dosing every 6 hours, and adolescents and adults usually require dosing every 8 hours, although this timing may vary by individual. The cost of immediate release theophylline is slightly higher than that of most of the time release formulas because more doses are taken and therefore more tablets need to be dispensed in a month. Many patients are stabilized to a set dose per 24 hours and then switch to a time release formula. Timed release. One caution for the patient is that the dose must be taken at the same time every day to have steady serum theophylline levels. Monitoring. Patients taking theophylline need to be monitored closely for signs of toxicity. When therapy is initiated, theophylline levels should be drawn frequently as the dosage is titrated. Once the patient is stabilized and has a steady theophylline level, then monitoring should be done every 6 to 12 months. Levels may need to be checked more frequently if a new medication is added to the patient's regimen, or if the patient has a change in overall health that may affect the ability to metabolize or excrete theophylline. Patient education. The patient should be instructed to take the medication exactly as prescribed. Missed doses or irregular timing of doses can cause wide variations in the serum theophylline level, resulting in either subtherapeutic or toxic levels. Toxicity should be discussed with any patient who is taking theophylline. Patients who are having signs of toxicity may mistakenly think they have a viral illness. The symptoms to report include nausea, vomiting, insomnia, jitteriness, headache, rash, severe GI pain, restlessness, convulsions, or irregular heartbeat. Patients should avoid large amounts of caffeine containing beverages, which can increase the adverse effects of theophylline. Explain that theophylline elimination may be influenced by the patient's diet. A diet that is low in carbohydrates and high in protein increases the elimination of theophylline. A diet that is high in carbohydrates and low in protein decreases the elimination of theophylline, and a diet that contains a lot of charcoal broiled foods accelerates the hepatic metabolism of theophylline. Hello, everyone. Today we will be continuing the topic of drugs affecting the respiratory system. Inhaled anticholinergics are used primarily to treat COPD, although ipratropium may be used in combination with albuterol as the emergent treatment of an asthma exacerbation or when a patient is intolerant to beta 2 agonist. Ipratropium bromide, with the brand name being Atrovent, is a quaternary amine anticholinergic that is structurally similar to atropine. It is available as a single medication, with the brand name being Atrovent, or combined with albuterol, with the brand name being Combivent. Tiotropium bromide, with the brand name being Spiriva, and aclidinium bromide, with the brand name being Tudorza Pressair, are inhaled anticholinergics available to treat COPD. All cause bronchial smooth muscle relaxation. Precautions and contraindications. Ipratropium is contraindicated in patients with hypersensitivity to atropine or atropine derivatives and for those with bromide sensitivity. Tiotropium is contraindicated in patients with hypersensitivity to ipratropium or tiotropium. The inhaled anticholinergics, which include aclidinium, ipratropium, and tiotropium, should not be used for the treatment of acute bronchospasm. Ipratropium bromide is pregnancy category B. Aclidinium and tiotropium are pregnancy category C. Their safety in pregnancy has had limited study. Therefore, inhaled anticholinergics should be used in pregnancy only if clearly indicated. The safety and effectiveness of ipratropium have not been established in children younger than age 12. Providers may use ipratropium in younger children as an adjunct to beta agonist therapy, with the brand name being albuterol, in acute exacerbations of asthma, per the NAEPP Expert Panel Report 3. Adverse drug reactions. The most common adverse drug reaction reported with ipratropium is cough. Also reported are the related symptoms of hoarseness, throat irritation, and dysgeusia, which is altered taste sensation. Dry mouth is the most commonly reported adverse reaction to inhaled tiotropium, with the brand name being Spiriva HandiHaler, reported in 16% of patients in the manufacturer's clinical trials. Other anticholinergic effects that are reported in pre-marketing trials in less than 2% of patients include urinary retention, dizziness, drowsiness, and constipation. Rare allergic reactions include the following. Allergy to soybeans, legumes, or soy lecithin appear to be correlated with hypersensitivity to ipratropium bromide. Clinical use and dosage. The dose of ipratropium for adults with COPD is 2 inhalations or 36 micrograms 4 times a day for a total of 8 puffs per day. If using a nebulizer, the dose of ipratropium is 1 unit dose vial or 500 micrograms 3 to 4 times a day via nebulizer, with doses 6 to 8 hours apart. Ipratropium may be mixed with albuterol if used within 1 hour. Aclidinium bromide, with the brand name being Tidorza Pressair, is an inhalation powder administered via inhaler with 400 micrograms delivered via each actuation of the inhaler. Dosing for COPD is 1 inhalation twice a day. Tiotropium, with the brand name being Spiriva, is a dry powder capsule administered via a patented HandiHaler device. The dosage for COPD is 2 inhalations of a single 18 microgram capsule once daily. Asthma. The adult dose of ipratropium for asthma maintenance is 2 to 3 inhalations 4 times a day. It should not be used for exercise-induced asthma. For children younger than age 12 years, the dose is 1 or 2 inhalations every 6 hours. The ipratropium albuterol combination, with the brand name being Combivent, is a second-line quick-relief medication in the treatment of asthma. Each inhalation of Combivent administers 103 micrograms of albuterol sulfate and 18 micrograms of ipratropium bromide. The dose of Combivent in adults is 2 to 3 inhalations 4 times a day, and in children younger than age 12, 1 or 2 inhalations every 6 hours. Tiotropium and aclidinium are not indicated for the treatment of asthma. Cost. The cost of the combination product Combivent is $420 or $250 for DuoNeb, which is an ipratropium and albuterol nebulizer solution, per 30 vials, a significant cost savings over prescribing the 2 products individually. The cost of 1 month's worth of capsules for the tiotropium, with the brand name being Spiriva HandiHaler, is $415. The cost of the Spiriva Respimat is around $392 per month. Aclidinium bromide, with the brand name being Tidorza Pressair inhaler, costs $360 for 60 doses or 1 month's supply. Patient education. Ipratropium, aclidinium, and tiotropium should be used as prescribed. Overuse of bronchodilators leads to increased adverse effects, and using the bronchodilator less than prescribed may lead to increased bronchospasm and decreased pulmonary function. To use an inhaler properly, the patient should first exhale and then tilt the head slightly back and place the inhaler mouthpiece either about 2 inches from the open mouth or between the open lips. While inhaling, the patient should press down on the canister, breathe in slowly and deeply, and hold her or his breath for 10 seconds, count of 10, or as long as comfortable. If 2 puffs are prescribed, then the patient should wait at least 1 full minute between inhalations. If the patient is prescribed other inhalers, advise the patient to use the ipratropium first and wait 5 minutes before using the other inhalers as directed. Regardless of administration method, patients should rinse their mouth with water after inhaling ipratropium or tiotropium to minimize dry mouth. Leukotrienes are substances that induce numerous effects that contribute to the inflammatory process, including smooth muscle contractility, neutrophil aggregation, degranulation and chemotaxis, vascular permeability, and activation of lymphocytes. There are 2 LTRAs available for use in asthma. Zafirlukast with the brand name being Accolade, and Montelukast with the brand name being Singular, and 1,5-lipoxygenase pathway inhibitor, Xyluten, with the brand name being Zyflow. Pharmacodynamics: leukotriene receptor agonist. Zafirlukast is a synthetic, selective, and competitive LTRA of leukotriene D4 and E4. Montelukast is a selective LTRA that inhibits the cystenyl leukotriene receptor. 5-lipoxygenase pathway inhibitors. Xyluten is an inhibitor of 5-lipoxygenase, the enzyme that catalyzes the formation of leukotrienes from arachidonic acid. By inhibiting 5-lipoxygenase, Xyluten inhibits the formation of leukotrienes LTB4, LTC4, and LTE4, identified as components of SRS-A. Precautions and contraindications. The leukotriene modifiers are not to be used for primary treatment of an acute asthma attack. Zafirlukast should be used with caution in patients with hepatic dysfunction because it is extensively metabolized by the liver. If a patient has alcoholic cirrhosis, the clearance of zafirlukast is reduced by about 50% to 60%. Leukotriene modifiers should not be abruptly substituted for inhaled or oral steroids. Caution is advised as systemic corticosteroids are reduced. There have been reports that the reduction of oral steroid dose in some patients on zafirlukast has been followed by eosinophilia, vasculitic rash, worsening pulmonary symptoms, cardiac complications, and or neuropathy. Caution should be used in prescribing any of the leukotriene modifiers to lactating women because the effects on infants are unknown. Zafirlukast and Montelukast. Hypersensitivity. Chewable Montelukast, patients with phenylketonuria. Xyluten, patients with active liver disease. Adverse reactions. The most common adverse reaction reported with zafirlukast use is headache. GI upset, myalgias, and fever are reported in a small percentage of patients. There is a reported increase in respiratory infections in patients older than age 55 years who are taking zafirlukast. The respiratory infections were usually mild to moderate and associated with co-administration of inhaled corticosteroids. Clinical use and dosing. Zafirlukast is indicated in the treatment of chronic asthma in children aged 5 years or older and in adults. Montelukast is indicated for use in the treatment of persistent asthma and for patients aged 12 months or older. Montelukast may be prescribed for the prevention of exercise-induced bronchoconstriction in adolescents aged 15 years or older and in adults. Xyluten is indicated for the treatment of persistent asthma in children aged 12 years and older and in adults. Monitoring. Monitoring of improving or worsening asthmatic symptoms, bronchodilator use, and pulmonary function is necessary to determine the efficacy of the leukotriene modifiers. Patients should be monitored for new onset of neuropsychiatric symptoms, including depression or behavior change. Administration. The patient must take the medication as prescribed, even if symptom-free. These medications are not for acute episodes of asthma. Patients must continue to use the bronchodilator inhaler for acute episodes of bronchospasm. Pregnant or nursing women should not take these medications. Patients should be aware of significant drug interactions with leukotriene modifiers because of the way these drugs are metabolized by the liver. Adverse reactions. Patients and parents of pediatric patients should be informed of the potential for neuropsychiatric events, including agitation, aggression, anxiousness, dream abnormalities and hallucinations, depression, insomnia, irritability, restlessness, suicidal thinking and behavior, including suicide, and tremor. Any new neuropsychiatric symptoms should be reported to the provider. Lifestyle management. Lifestyle management issues related to the disease process should be discussed. They often include the following. 1. The patient needs to self-monitor respiratory status with a peak flow meter to determine the effectiveness of the medication prescribed. 2. The patient should avoid or quit smoking. 3. The patient should avoid environmental triggers for asthma at home, work, and school. Hello everyone. Today we will be continuing the topic of drugs affecting the respiratory system. Corticosteroids. The Expert Panel Report 3 states that corticosteroids are the most potent and effective anti-inflammatory medication currently available. Their anti-inflammatory effects lead to the reduction in the severity of asthma symptoms, increased peak flow readings, and decreased airway hyperresponsiveness. In general, inhaled steroids are safe and well tolerated at recommended dosages and can be used both by children and adults. Corticosteroids are also used intranasally for the treatment of allergic rhinitis. Precautions. All of the inhaled corticosteroid preparations are contraindicated in acute status asthmaticus or when intensive acute therapy is warranted. They should not be used for relief of acute bronchospasm. Care should be taken when substituting any of the inhaled corticosteroids for oral corticosteroid therapy. There have been deaths due to adrenal insufficiency in asthmatic patients who were switched from oral to inhaled corticosteroids. Inhaled corticosteroids should be avoided in patients with Cushing syndrome. They should be used with caution in patients with ocular herpes simplex infections, tuberculosis, oral or nasal surgery or trauma, healing nasal septal ulcers, and untreated respiratory infection that include viral, fungal, or bacterial. All of the inhaled corticosteroids are pregnancy category C. There have been no well-controlled studies of the effects of inhaled corticosteroids during pregnancy. Drug interactions. There are no known drug interactions with inhaled triamcinolone, flunisolide, mometasone, beclomethasone, or cyclacinide. Ritonavir significantly increases fluticasone serum concentrations and may lead to increased corticosteroid effects on fluticasone. Ketoconazole increases plasma concentration of fluticasone and budesonide when co-administered. Clinical use and dosing. Asthma. The inhaled corticosteroids are the preferred long-term control medications for managing the inflammatory process associated with asthma. All patients with mild persistent asthma are started on a low dose of inhaled corticosteroids. If the patient has moderate persistent asthma, then the patient is prescribed daily low to medium dose inhaled corticosteroids combined with a long-acting beta agonist. Severe persistent asthma requires daily high-dose inhaled corticosteroids and long-acting beta agonist. Allergic rhinitis. Nasal corticosteroids are used to manage the inflammatory response associated with seasonal or perennial allergies. Intranasal corticosteroids may be used once or twice a day, depending on the drug chosen. Once clinical improvement occurs, usually in 3 to 7 days, the dose can be decreased. Monitoring. The patient who is using inhaled corticosteroids needs to be monitored for adverse effects and effectiveness of the medication and the asthma disease process. If high-dose inhaled corticosteroids are used for a long time, blood glucose and potassium should be monitored, as well as growth in young children. Patient education, administration. Patients who are concurrently using an inhaled bronchodilator should administer the bronchodilator first and wait several minutes before using the inhaled corticosteroid. This procedure enhances the absorption of the steroid in the bronchial tree. The administration of inhaled corticosteroids via an MDI can be difficult for most adults and all children. Learning to coordinate the release of the medication from the inhaler with a deep breath is difficult. Written and pictorial instructions are available with the inhaler, but the provider must not assume that the patient understands the proper method of administering inhaled medications. Patients should rinse the mouth with water after each use to help reduce dry mouth, hoarseness, and candidiasis infection. The patient should clear the nasal passage of mucus before using intranasal corticosteroids. If the nasal passages are swollen and blocked, the patient should administer a topical decongestant before using an intranasal corticosteroid. Rinsing the mouth with water after use will reduce the rare chance of candidiasis infection associated with intranasal corticosteroid use. Adverse reactions. The patient should be advised to notify the provider if sore mouth or throat occurs. Oral candida infections are possible and the patient should get prompt treatment. The patient should be aware of the possibility of dysphonia developing. Rinsing the mouth with water and using a spacer device will decrease its incidence. Other adverse effects occur less often, but the patient should be aware of them and instructed to notify the provider if adverse effects begin to develop from the inhaled medication. Less common adverse drug reactions include the following: oral candidiasis, cataracts, bronchospasm, hypothalamic pituitary adrenal axis, also known as HPA suppression, pulmonary infiltrates with eosinophilia, nasal irritation, itching, sneezing, and dryness, bloody nasal mucus, or epistaxis. Lifestyle management. Lifestyle management issues related to the disease process should be discussed. They often include the following. 1. Patients need to self-monitor their respiratory status with a peak flow meter to determine the effectiveness of the medication prescribed. 2. The patient should avoid or quit smoking. 3. The patient should avoid environmental triggers for asthma at home, work, and school. Antihistamines. Uses. Reduce or prevent most physiological effects of histamine at the histamine 1 or H1 receptor site. Strongly block the action of histamine. Decrease the flare and itch response. The first antihistamines became available in the 1940s, with the still widely used diphenhydramine first available in the 1950s. They are referred to as first-generation antihistamines. The 1980s brought a new generation of non-sedating antihistamines that provided relief to allergy sufferers without causing the drowsiness of the earlier medications. They are referred to as second-generation antihistamines. New antihistamines that are longer acting and have better adverse effect profiles continue to be developed. Precautions. The precautions and contraindications differ between the first-generation and second-generation antihistamines. First-generation antihistamines. Antihistamines cause varying degrees of sedation and drowsiness and reduce mental alertness. Therefore, patients should not drive or perform other tasks requiring mental alertness while taking the first-generation antihistamines. The first-generation antihistamines are pregnancy category B. First-generation antihistamines are contraindicated in newborns and premature infants who may have severe reactions such as convulsions. Breastfeeding is also a contraindication for the use of first-generation antihistamines because all of the medications are excreted in breast milk and they may decrease milk production. Second-generation antihistamines. The second-generation antihistamines are generally not recommended during pregnancy, especially during the third trimester, because of risk to the fetus for seizure. Loratadine, cetirizine, and levocetirizine are classified pregnancy category B. The other second-generation antihistamines, loratadine, desloratadine, and fexofenadine, are pregnancy category C, and their use should be avoided. Fexofenadine is not recommended for children younger than age 6. Loratadine may be prescribed to children as young as age 2. Cetirizine syrup and desloratadine syrup may be used in children as young as 6 months. First-generation antihistamines adverse drug reactions include the following: sedation or fatigue, dizziness, headache, tinnitus, lassitude, disturbed coordination, nausea or vomiting, irritability/nervousness, blurred vision, diplopia, tremors, increased/decreased appetite, epigastric distress, constipation, diarrhea, dry mouth, urinary retention, and dysuria. Second-generation antihistamines adverse drug reactions include the following: drowsiness is greatly reduced, minimal incidence of dry mouth, 5% or less. Symptoms caused by first-generation antihistamines can be alleviated by switching to second-generation antihistamines. Clinical use: respiratory allergies. Most antihistamines are effective in the treatment of seasonal allergic rhinitis and conjunctivitis. Antihistamines effectively treat the sneezing, rhinorrhea, watery eyes, and itching of eyes, nose, and throat associated with seasonal allergies or hay fever. Hypersensitivity reactions. The first-generation antihistamine, diphenhydramine, is usually the drug of choice for patients with acute hypersensitivity reactions. It is available in oral tablet, capsule, and liquid forms without prescription, and in parenteral form for acute intramuscular or IV use. Urticaria and angioedema. In urticaria, histamine is the primary mediator, and therefore the antihistamines are the drugs of choice and quite effective. Nighttime sleep aid. Diphenhydramine is available without prescription as a sleep aid and is a safe treatment for occasional insomnia. The recommended dose for adults is 50 milligrams at bedtime. Motion sickness/antiemetic. Dimenhydrinate, with the brand name being Dramamine, is used in the treatment and prevention of nausea, vertigo, and vomiting associated with motion sickness. Lifestyle management. Lifestyle management related to the disease process needs to be discussed with the patient. Points to discuss often include avoidance of known allergens and using environmental methods to control dust mites and other common allergens. Available dosage forms are presented in Table 14-12. Hello everyone. Today we will be finishing up the topic about drugs affecting the respiratory system. Decongestants. Decongestants are widely used for congestion associated with the common cold and allergic rhinitis. Many preparations are available without a prescription and in many formulations. They come in liquid, tablet, capsule, nasal spray, or drops, providing a variety of methods of administration. Contraindications. There are only a few absolute contraindications to taking decongestants. The oral decongestants are absolutely contraindicated for patients on concurrent MAOI therapy. Concurrent use of these medications may result in severe headache, hypertension, hyperexia, and possibly hypertensive crisis. Oral decongestants are also contraindicated for patients with severe hypertension or coronary artery disease. Adverse effects are minimal at recommended doses unless a patient is sensitive to sympathomimetics. Central nervous system effects may include anxiety, tenseness, restlessness, headache, lightheadedness, dizziness, drowsiness, tremor, insomnia, hallucinations, psychological disturbances, central nervous system depression, and weakness. Of these central nervous system effects, the most common adverse effects are restlessness and tremor. Cardiovascular adverse effects include transient hypertension, arrhythmia, and cardiovascular collapse with hypotension, palpitations, tachycardia, and bradycardia. These adverse reactions are rare at recommended doses in healthy individuals. Topical decongestants have adverse reactions related to the intense vasoconstrictor effect of the nasal spray or sensitivity to additives such as sulfites. Transient stinging is the most common adverse effect reported. Burning, sneezing, dryness, and local irritation are all reported with topical drugs. The most significant adverse reaction with topical decongestants is rebound congestion, also known as rhinitis medicamentosa, with prolonged or chronic use. This does not occur with short-term use, such as 3 to 5 days. Clinical use: nasal congestion. Oral decongestants are used for the temporary relief of nasal congestion due to the common cold, sinus infection, and allergic rhinitis. They may be used to promote nasal or sinus drainage and are also indicated in the relief of eustachian tube congestion. Topical decongestants are indicated in the symptomatic relief of nasal congestion due to the common cold, sinus infection, and allergic rhinitis. As previously mentioned, topical decongestants are only for short-term use because of the rebound congestion of long-term use. Nasal decongestants may also relieve ear block and pressure pain in air travel, especially if a patient is suffering from a common cold or sinus infection. Short versus long-acting. There are short and long-acting forms of both oral and topical decongestants. In general, the short-acting forms are better tolerated and have fewer adverse effects. The longer-acting forms are useful for patients who require all-day or all-night relief if the patients can tolerate them. Lifestyle management. Patients should maintain adequate hydration while taking decongestants to keep mucus mobile. They should also refrain from smoking when they are congested. Caffeine-containing products may cause tachycardia if ingested with decongestants. Antitussives. Antitussives are widely used by patients to self-treat coughs. It is essential for the healthcare provider to educate the patient on the useful physiological mechanism a cough provides by clearing the airway of secretions and foreign material. Therefore, a cough should not be suppressed if it is protecting the airway. Exact mechanism of action poorly understood. Precautions. Antitussives are not to be used for persistent or chronic cough caused by smoking, asthma, or emphysema. In asthma, antitussives may impair expectoration and thus cause increased airway resistance. Expectorants must not be used by patients with excessive respiratory secretions for the same medical reason. Patients must be cautioned not to self medicate their cough for long periods, more than 7 days, without seeking the care of their healthcare provider. If high fever or rash accompanies a cough, patients must be seen by their healthcare provider. Lifestyle management. The patient with a cough should be encouraged to increase fluid intake to improve the viscosity of the respiratory secretions. The patient should refrain from smoking and stop smoking if possible. Avoidance of respiratory irritants and people with respiratory infections will decrease the incidence of cough. Expectorants. Guaifenesin is the only expectorant ingredient listed by the FDA panel as having scientific evidence of safety and efficacy. Guaifenesin is indicated as an expectorant in the symptomatic treatment of cough due to the common cold and mild upper respiratory infections. Precautions. Guaifenesin is not to be used for persistent cough, such as that found with smoking, asthma, or emphysema. Cough related to heart failure, or angiotensin converting enzyme, also known as ACE, inhibitor therapy should not be treated with guaifenesin. A cough accompanied by high fever or lasting longer than 7 days should be evaluated by a healthcare provider. Guaifenesin is pregnancy category C. There have been no problems documented in breastfeeding women taking this medication. Use in children as young as age 2 years is considered safe. Adverse drug reactions include the following, the most common being GI upset, nausea, and vomiting. Less common include drowsiness, diarrhea, dizziness, rash, and headache. Drug interactions. There are no drug interactions of significance with guaifenesin. However, guaifenesin may cause false readings in certain laboratory determinations. Clinical use. Dry non-productive cough. Guaifenesin is indicated in the symptomatic relief of dry non-productive cough with mucus in the respiratory tract. Lifestyle management. Patients should be instructed to remain well hydrated while taking guaifenesin and they should refrain from smoking.